I will start. Welcome to our roundtable for the evening on prenatal treatment use. ResearchCon saved the best for last, I believe. I will start with a little bit of housekeeping if that's all right. So first and foremost, we will have, I will share a little bit about my experience of treatment in utero, and then we'll get to hear from Dr. Szentpetery about the research, and then we will pass it off to you all in the audience for Q&A, and we'll save about 30 minutes at the end for that time. So we do ask that you save your questions for the end and that you leave your cameras and your microphones off until that time comes. I'm also getting over a cold, so forgive me if I need to clear my throat a couple of times. Okay, so we will be recording the presentation time where I share and Dr. Szentpetery shares, and then when it gets to Q&A, we will delete the recording so that will not be posted, so that hopefully everyone feels more comfortable asking the questions. And because it is a roundtable, the nature of this, we want to foster a spirit of inclusivity. We want to make sure that we know that everyone's on a different journey. We want to make sure everyone has a chance to ask their questions. So please be conscientious of the time, as well as respectful of everyone else's experience. So without too much more of a spiel, I will go ahead and share a little bit about my experience. So my name is Stephanie Marquardt. I am a mental health therapist. I'm a carrier of cystic fibrosis. And most importantly for tonight's talk, I am the mother to our incredible daughter, Hazel. Hazel is almost a year old now. She was born with cystic fibrosis, and she has been receiving ETI since 27 weeks gestation. For those of you who may or may not be familiar, ETI is elexacaftor, tezacaftor, ivacaftor, more commonly known as Trikafta, but we will be referring to it as ETI for tonight's talk. So the way I heard about treatment in utero was actually never directly from a medical provider. At 20 weeks pregnant, I had the anatomy scan, and in that scan, my OBGYN found some brightness in the bowel. And she said, you know what, it's probably nothing, don't worry about it, but let's go ahead and do the genetic testing just in case. So 4 weeks later, we received a really hard phone call from our genetic counselor that there was a very high probability that our daughter would be born with cystic fibrosis. My husband and I did not know what cystic fibrosis was. We certainly did not know we were carriers of it. So this was a very, very steep learning curve. But even from the beginning, I was asking our care team, okay, what can we do? How can we get ahead of this? How can we prevent it? Is there anything that we can do? And our genetic counselor was very sweet and encouraging, but she said, hey, there's really nothing you can do now. The good news is that once she's old enough, she'll qualify for these modulators. But until then, you just kind of hang tight. So my husband and I sat on this really hard news for a weekend, and we were reading what we did not know at the time was really outdated, incredibly outdated information on her prognosis. And for a very brief period of time, I was actually considering a termination. It wasn't until then when I told our care team that a termination was something that was on the table that my genetic counselor then offered to put me in contact with a fellow mom in the community who was in a very similar position, and she had advocated for ETI treatment in utero. So it was from this mom that I heard for the very first time about prenatal treatment, and I basically said, I will have what she's having. This mom also connected me to other moms throughout the world who had done or who were currently doing the same thing, and she connected me through social media. So between this mom and social media connections, I was able to learn how to advocate, what to advocate for, and how to gain access to ETI treatment. So I went back to my OBGYN team and I said, hey, I'll have what she's having. So they somewhat reluctantly gave me a referral to an adult pulmonologist. And in the meantime, I went ahead and had an amniocentesis just to confirm that Hazel would be born with cystic fibrosis, and that did come back confirming a CF diagnosis, double delta. So then at 24 and a half weeks or so, I got the referral to the adult pulmonologist. He thankfully was very quick to prescribe ETI, but warned me that we probably would not get it approved by insurance. And if we don't, then that's kind of the end of the road. I was not willing to accept no for an answer. So while he was working on insurance approval, I was reaching out to these other moms that I met through social media, asking them how they had gotten insurance approval, what that journey looked like for them. I was repeatedly given the names of a couple of physicians in the community who have more experience getting ETI approved for CF carrier moms, Dr. Szentpetery being one of them. And she was kind enough to collaborate with my adult pulmonologist and help fight for insurance approval. So at 27 weeks pregnant, I did get ETI approval, and I started taking it then. So from 27 weeks on up until Hazel was 2 weeks old, I was taking ETI. I very thankfully did not have any side effects from taking ETI. So once Hazel was born, she continued receiving breast milk, or she continued receiving ETI through my breast milk for the first 14 days of her life. And then at 15 days old, I decided to switch to direct dosing. And then she's been receiving ETI through direct dosing ever since. When she started receiving it in gestation at 27 weeks, it took about a month before we saw an improvement in that brightness of the bowel or echogenic bowel. It did not completely resolve, but it was significantly, it was not nearly as bright. And then once she was born, she passed her meconium, no problem. She was born pancreatic sufficient. Her sweats are in the low teens. Her newborn CF screening actually came back negative because the ETI treatment has been working, or was working so well. And now she is almost a year old. She continues to receive ETI. We call them sprinkles. She takes her sprinkles twice a day. And she's never been on enzymes. There's no percussion therapy. There's no talk of a vest. And I know we are very fortunate to have this story. It is not everyone's story, and I'm well aware of that. But one of the reasons why I'm so passionate to get to share this story today is because I just hope that every family who is in a similar position gets to make an informed decision. Had I not gone through the process of grief and for a very brief period of time questioning that termination, I'm not sure if I would have been connected with this mom who shared this information with me. So I'm really passionate about every family having access to this information and getting to decide what's best for them and for their family. So that is a little bit about our story. Happy to answer any questions at the end. I'm sure y'all have some thoughts that might be coming up. But I will go ahead and introduce Dr. Sylvia Szentpetery. So she is a pediatric pulmonologist and pediatric cystic fibrosis program director at the Medical University of South Carolina. Her research focuses on the effect of modulator therapies on early life outcomes of infants and children with cystic fibrosis. Most recently, she has participated in efforts caring for infants exposed to modulators prenatally, which is an area of ongoing study.
Thank you, Stephanie, and thank you for sharing your story. I know that putting a personal touch to this concept is really helpful for folks to understand. And it's something that within the CF community we've been talking about and considering and helping families with in regards to decision making for quite some time. But to give some background as to what we know about prenatal treatment with ETI, I'd like to share some information about the US case data that we have for prenatal treatment. And it looks like everything's advancing well on the slides. So just some housekeeping disclosures. I do have some research relationships related to cystic fibrosis with a few companies, but none of these have any significant effect on what I'll be describing today. To go back a bit regarding how all of this came to be, we started actually with the case at the top of the screen from 2021. Thank you, Dr. Fortner, for publishing this important information with mothers having cystic fibrosis and continuing ETI, and then the concept of that trickling out into other parts of the CF community. This first case was really quite important in highlighting the potential effect for a child with cystic fibrosis who received ETI prenatally having a positive impact on their own disease. So this was the first case described of an infant with a negative newborn screen, as Stephanie described for her own daughter. And then some other cases, one from our center regarding rescue of meconium ileus by treating a carrier mother, and additional F508del infants who had meconium ileus and benefit from prenatal ETI. So these cases have continued to trickle through the various medical literature, but what we'll be focusing on today is highlights from about 10 cases of infants who have attempted to or been exposed to these therapies. So our objectives: we'll describe the current collective experience with prenatal use of ETI in the United States. We'll talk about timing of ETI initiation and how that has related to changes on prenatal ultrasound. We'll describe available delivery and newborn outcomes, review existing data for infants after delivery in the early newborn period, and then also talk about plans for the future. So we have 9 cases from our original data set of infants born between 2021 and 2023. 2 of the mothers had CF and 7 were carrier mothers. You can see the genotypes of the CF mothers here and the carrier status genotypes for the carrier mothers below. In regards to parents, again, there were a majority of F508del carriers among the carrier mothers, and 2 different mutations in the maternal group with CF. And then across the paternal carriers for the fathers in the group, the vast majority also carried 1 copy of delta F508. So as you'll see, the majority of babies within our data set were F508del homozygous, or carried 2 copies of delta F508. There were 2 families within the group that had a prior CF diagnosis of another child. Almost 80% of pregnancies did have an amniocentesis to formally diagnose CF, with the mean gestational age, a diagnosis being just under 19 weeks. 2/3 of the infants had that delta F508 homozygous genotype, and just over 50% were female. All families had insurance, with the majority of families having had prior children, either with or without CF, and on average, the maternal age was 31 years, with all parents reporting Caucasian race. 8 of the 9 infants had abnormal prenatal ultrasounds, with the vast majority having some suggestion of meconium ileus. 1 was called a frank meconium ileus, and the remainder had descriptions of either echogenic, overshadowed bowel, or dilated bowel loops that suggest a blockage in the bowel. 1 infant also had a finding of polyhydramnios, or excess amniotic fluid surrounding the fetus. On average, the initial abnormal ultrasound was noted around anywhere between 18 and 29 weeks gestation. In regards to treatment discussion and timing of treatment, the initial discussion of treatment occurred at an average of 22 weeks gestation, with the follow-up with a prescription for ETI coming on average 2 weeks after that initial discussion. Most patients were prescribed drug by a pediatric provider, with 1/3 of mothers being prescribed drug by an adult provider. And in regards to the initiation of conversation about starting ETI, a large proportion of these conversations came from parental interest, with about 1/3 coming from the pediatric care team involved, and the remainder coming from either an adult provider or maternal care doctor, such as an OB or maternal fetal medicine specialist. There was 1 mother who was already on ETI for her own diagnosis of cystic fibrosis. Prescription process was variable across the group. If you've had any experience with specialty drugs, this can be a challenging piece of the medical care puzzle, with under 50% of the folks within the treated group having approval on the first pass of the prescription being processed. That was the most frequent outcome, but a fair number did also require some sort of appeal. So 2 families required an appeal process, and 1 had to go through what we call a peer-to-peer, where a physician from the care team speaks to a physician at the insurance company to get the medication approved. And again, there was 1 mother who was already on an approved prescription for her own cystic fibrosis. In regards to the prenatal ultrasounds, again, these occurred anywhere between 18 and 29 weeks in relation to the bowel findings, with the polyhydramnios or excess fluid having been identified closer to 33 weeks. For these infants, we see that they had ETI initiated in general a few weeks after that initial ultrasound finding, and resolution of the bowel findings, or in the final patient, the polyhydramnios, within some number of weeks after starting. And we'll look at that in a little bit more detail next. So time to ultrasound resolution. Going too fast here, apologies. For the first infant whose abnormal ultrasound occurred at just under 19 weeks, they had 7 6/7, or just under 8-week time on drug before they had resolution of their echogenic bowel. And the group had quite a varied time course depending on when they started ETI and how quickly ultrasounds were pursued, for as little as 2 weeks from drug initiation to resolution of bowel abnormality to as long as 15 weeks at the longest. So on average, when we look at the group altogether, the mean ultrasound abnormality finding occurred at around 22 weeks gestation. ETI prescription occurred about 3 weeks later, and the resolution of ultrasound findings occurred about 6 weeks after starting ETI. In regard to infant delivery, all infants were vigorous, with a mean gestational age of just under 39 weeks, with the majority of infants being term, with 2 being delivered within the late preterm time period, anywhere from 36 weeks and 1 day to 41 weeks and 4/7 days. Again, all infants came out crying and excited to be in the world. 1/3 had cesarean delivery. Again, 2 were late preterm, and 11%, or 1 delivery, was complicated by a diagnosis of preeclampsia or significantly high blood pressure and sometimes lab abnormalities that can be seen in pregnancy. 5 of the infants were admitted to a neonatal ICU, which is not typical for what we would expect for any given newborn. Most infants are admitted to a newborn nursery where care is much less intensive than an ICU. 1 of the infants was among the 2 late preterm infants and had poor feeding, vomiting, and required a tube for feeding. Of the 4 term infants that were admitted to the neonatal ICU, 2 required just brief observation based on the circumstances of their abnormal prenatal ultrasounds. 1 underwent what we call a sepsis rule out. So watching the baby to ensure that there are no adverse events occurring, no signs of infection, and typically that may include giving the baby antibiotics for about a 48-hour period. 1 infant did have some gastrointestinal symptoms and had delayed but not blockage of meconium. They did pass the meconium with the assistance of a barium enema, which is a type of procedure where fluid is brought into the GI tract from below, and the blockage or stool that is remaining inside can then be cleared more effectively. Newborn screen, as Stephanie mentioned, was somewhat variable across the group. All infants had standard newborn screening based on their state. The mean blood test that we look for reflecting a diagnosis of cystic fibrosis was at a somewhat elevated level, but not in the range of ultra high that we might expect for many babies with cystic fibrosis. One result did end up closer to that range with a value above about 150, and that ultra high designation varies state by state depending on your lab. And 3 of the infants were noted to have a negative newborn screen. So interesting that that also occurred in several of the babies within this group. Those babies had the genotypes of delta F508 homozygous, or 2 copies of delta F508, delta F508 and 1 copy of R553X, and delta F508 and 1 copy of 5G12TG. When we look at the newborn screen results and genotype and sweat test all together, there are some interesting findings. So for example, one baby who had 2 elevated newborn screening results, or IRTs, and a positive newborn screen, then later had a much lower sweat chloride or sweat test than we would expect based on the genotype and their positive newborn screen. And my expectation is that because these sweat chloride collections may have varied over time, depending on if the baby was continuing to receive ETI through breast milk, these might explain some of these differences. Some babies had negative newborn screens. So, for example, this baby who was also delta F508 homozygous genotype then had a sweat chloride that was technically positive, but quite low for what we typically see with that genotype. And then other babies also had negative newborn screens, sometimes with a more potential varying clinical consequence of their genotype. On average, across the whole group, sweat chloride was just under 70. And again, the IRT value, or newborn screen related lab test, was about 88. In regards to feeding, most infants were breastfed and through that received ongoing ETI after birth. Among the group who was breastfed and had ongoing ETI, the mean fecal elastase, or stool test that helps to reflect whether the pancreas is working properly in regards to needing supplemental enzymes. This was above the cutoff for what we would consider pancreatic sufficient, whereas among the 2 infants where ETI was withdrawn for a variety of reasons, they had clear pancreatic insufficiency on their stool elastase tests. Just under 50% of the infants were initiated on pancreatic enzyme replacement therapy, which is a very common practice in newborns with a delta F508 homozygous genotype, or even just a known clinical diagnosis of cystic fibrosis. 2 of these infants did not receive any ETI through breast milk and remained pancreatic insufficient, but 2 of those infants continued receiving ETI through breast milk, and one did what we would consider to be a conversion or transition to pancreatic sufficiency, and one improved, so had fecal elastase rising over time and getting close to that cutoff of about 200 micrograms per gram that typically suggests pancreatic sufficiency. Among infants receiving ETI through breast milk, one mother had to stop just prior to birth as she planned to formula feed. 2 mothers stopped later, between 3 and 4 weeks. One related to an insurance challenge, and then an additional case related to an unconjugated high bilirubin. However, of the 5 infants who continued to receive ETI through breast milk, these were all found to be pancreatic sufficient. So again, in the first year of life, 5 infants 4 of whom were Delta F508 homozygous, had normal stool elastase or normal pancreas function, which would be unexpected based on the genotype and typical clinical course. All infants had monitoring with lab work after delivery. Most had tests that reflect liver function, gallbladder function, and these were done as often as once a month, but more often closer to once every 3 months. In general, the lab results were most often normal or only slightly elevated, if elevated at all. Sorry about that. My mouse is doing funny things. There was one single report of a high lipase, so elevated pancreas lab test that can sometimes reflect pancreatitis during a period of breastfeeding ETI exposure. And again, that single report of unconjugated high bilirubin that had prompted the mother to stop taking drug and using that through breast milk to provide drug to baby that we discussed a few moments ago. All infants had ophthalmologic screening, which is recommended for anyone under the age of 18 who's exposed to ETI. And this ranged anywhere from 16 days of life to 9 months of life. And no infants had any cataracts identified. Overall, they had good growth with a range of weight percentiles from the 2nd to the 99th. So some much more robust than others. But on average, a 37% weight percentile, unadjusted for the 2 late preterm infants who we don't hold to as high as standards for a term baby. And then length percentiles with an average of about the 42nd percentile, and weight for length, or putting those two together, similar to what we think about with body mass index for adults, just about the 50th percentile. Among those who attempted ETI, 4 of the infants within our group are reported as having transitioned to their own modulator therapy, so no longer receiving it by breast milk, but at some point later in infancy or toddlerhood, shifting to their own prescription. This occurred anywhere from age 4 months to age 21 months, at an average of 10 months across the group, with half having their own prescribed label-approved dosing. So for those under age 2, that would be Lumicaftor, Ivacaftor, or Orkambi, and 1 infant receiving maternal ETI, and 1 infant having received early insurance approval and early access ETI. So what can we take away from this information from this group of infants? CFTR modulator use is increasing during pregnancy among carrier mothers. We've certainly seen some changes in disease hallmarks that we expect related to cystic fibrosis, namely pancreatic insufficiency and meconium ileus, being successful interventions for many infants within the group. And there have also been case reports of preservation of male fertility, or the vas deferens, that continues to be of high interest as a potential outcome for prenatal ETI treatment. There are implications in newborn screening, so the possibility for a newborn screen to be negative, and that's an important piece for families and care providers to be aware of during the newborn time period. And it also highlights that ongoing education, access, and resources for folks who might be considering prescriptions for ETI for pregnant mothers are really incredibly important. Lastly, we continue to study this concept and gather data as it evolves and cases occur, but a more focused area of research is really needed to help us to determine safety, efficacy, and look at multiple scenarios where this medication might be used.